Okay, I'm going to invite the next speaker, who is a preeminent cardiologist in Thailand, Dr. Wiraj, to talk about tips and tricks for complex bifurcation PCI with cases and demonstrations.
First, good morning, everybody, and thank you for this chance to have a chat something here. My talk is a topic of tips and tricks. So this is something I gather from my experience and some learning from my point. So it's a compilation of cases. This is my disclosure. So first of all, strategy for every PCI nowadays for complex PCI, lesion preparation is the most important. Here's a case of the post-CPG patient, 70 years old with a calcified bifurcation. He have a failed the graft to LRD, so we have to fix this left main lesion. So at first, the IVAS can enter the LRD but show eccentric calcified plaque, but because the angle of the circumflex, IVAS cannot enter. So we prepare the lesion by using a rota into the circumflex, and you can appreciate that pre and post rotator, you change the geometry of this bifurcation angle, so that this may facilitate the stenting of the next procedure process, and we can make the two stent technique by the decay crush easier and have a nice result. And this is we have a chance to follow up the patient a year later, and the result is still very good. So the lesion preparation is the key of everything. Now for the technique for this bifurcation, most of us will have a difficult side branch wiring problem. This is a very classic technique, the diffraction technique. You use a balloon to block the distal main branch to facilitate the dry into the angular side branch. But sometimes in my practice, I did not blow the balloon, so I just use a used balloon so that the bulky of the balloon can also replace this the full inflated balloon. And this is an example for the wiring technique with the diffraction. This case, I used a very low pressure balloon and then use a slippery wire. This is a whisper wire, so that this can move into the angulated side bands easier. The other way, at the time we do not have a special device. This is the last and the technique. You change the geometry by modify the plaque either by balloon or sometimes by rotator. But today we have a lot of the special catheters such as the dual lumen microcatheter, the angulated tip microcatheter that can help us to enter this difficult side bands, such as this technique of the dual lumen microcatheter. However, you have to familiar with the use of this catheter as well. And the most talk technique is the reverse wire technique, which you use the looped wire combined with the dual lumen microcatheter to send the wire beyond the bifurcation, and then use this looped wire to pull back into this side branch. However, you have to learn that sometimes it's randomly. Sometimes the wire is not always point to the direction of the side branch. So in case that the wire is the opposite, you have to manipulate the wire. But when it's become a loop, the direction of wire movement will opposite to your hand movement. So you have to practice to gain some experience to do that. The second is this is one of my complications, but I cannot find the picture. So this is an illustration that sometimes if you have a diffuse lesion in the distal main branch, a loop wire can sometimes cause injury of the vessel, either dissection or perforation. So should be careful. And the also always have a controversial about how long of the bending part of the loop. The longer of the bending part of the loop, you have to be careful that the zipper part of the tip of loop, but it makes it easier to enter the side branch as well. So this is a case example of the use of this reverse wire technique. You have to see that you can see that although the wire can go easily, but sometimes you have to face with the like a loop to how to release this loop before you can send this wire inside the reverse takeoff. Otherwise, when you push the wire directly, it will collapse into the main branch as well. So the most important is that how to exchange the angle, to replace the angle of the loop before you push the wire further into the side branch. The other one is the difficult device delivery. I think for a bifurcation technique, especially the true stent technique, you have to deal with the many device passing wire and stent. And this is a case of the very complex left main angulated. And this patient, even the diagnostic catheter cannot make a nice picture. When we do the PCI, we have to use a guide wire to facilitate the catheter engaging. And then after we tried to modify the plaque with the rotabator, both LAD and circumflex ostium, and also the use a balloon to pre-dilate it. This look like that the result is quite good enough. First stent we will always put in the difficult angle branch. This is circumflex, but you can appreciate that stent could not pass easily. Either use of the guide extension catheter sometimes is also not enough to support in case that the catheter is not well coaxial to the this one. So we have to modify the lesion with a balloon many times, and also use the dual sort of body wire technique to help modify the direction of the stent and the vessel geometry to allow the stent to push inside. This is how to deliver the stent in a complex situation. I will pass this slide. One of the technique that is for the difficult one is I call it the exchange balloon technique. You can use one small balloon to go inside the distal main branch and then pull it back simultaneously with the pushing the stent. Sometimes it also can help to deliver the stent in the very difficult anatomy angle. So in some cases, the no perfect guiding catheter that you can find. You have to familiar with the various balloon and stent technique to help you to push to send the device inside. Otherwise, many technique to protect the side branch, such as gel wire technique. But should be careful that when you use the gel wire technique, in the case that the calcified proximal main branch or a previous stent proximal main branch, this may make they can cause the entrap of the part of the wire that's at the proximal main branch. In this case, there's a previous stent in the proximal LAD, and after we put a gel XTY inside the diagonal and before stenting, the wire cannot be removed, and with the various micro catheter and small balloon also fail to retrieve this wire, and at last it's become uncoiled and snapped, and this become a long complication. So be careful of the gelling wire. I recommend that not to put the gel wire in a very calcified proximal main branch, or sometimes if you want to put it over there, try to deploy the stent with a lower pressure first before you go post-dilate. Should be changed to the rewiring first. And another one is a gel balloon. There are two gel balloon technique, the classic one and the modified one. It's up to your experience that which one you prefer. But when I tried the modified one, this is one case that almost caused some complication because diffuse long calcified lesion. I put the main branch stent in the distal RCA to the PL branch with a small balloon in the side branch. After I deployed the stent, I also inflate the side branch balloon. But when I inflate the side branch balloon, the balloon become bulky, and it's difficult to remove, especially when you have a long proximal main branch stent. So try to estimate the appropriate main branch length before you put this modified shell balloon. Other one is a difficult side branch rewiring after stenting. I think this is the problem of the beginner, but sometimes for the experienced one, it's also very difficult. For my experience, I prefer to use a single curve wire, and the curve is about diameter plus 1 or 2 millimeter to use to make it easier to cross into the wire. Otherwise, you can use my double lumen microcatheter to help to fast support this wire as well. And the most important in the modern bifurcation technique is the pot, because the pot can facilitate rewiring into the sideband as well as the balloon. Sometimes if you lost the wire during the procedure, the loop wire is something we recommend to cross the previous stent, but be careful of the space behind the stent. Even a loop wire can make a cross in this space. So after that, if you have this situation, I still prefer to use a used balloon, or sometimes if you have imaging, try to be careful to push imaging catheter inside, not too fast, because even IVAS catheter can cross behind the stent side as well. And this is some technique to help to support the balloon pushing into the side branch. One that I always use is a balloon anchoring technique in the main branch. Otherwise, this is my always practice that you have to do a two-step inflation of the balloon. After the tip of balloon can cross the strut of the stent, inflate into the low pressure first, and after that it deflate and push it a little bit further. It will be easier to push the balloon inside. And if the difficulty to push a balloon across this bifurcation, always think of the wire filing or wire wrapping. This problem, I try to find a way to protect, but it's still up to now have no way to protect. It's always happen when you when you put a device in and out many times, and then that will make the wire become wrapping. The only correction we have to remove the wire. The other one, you have to familiar with the stent design and the bifurcation. This is a case that consult me for the stent abrasion because of the previous stent in the crossover left main to RD have a restenosis at the ostium of the circumflex. This stent was done by using previously a 3O stent, but did not have a pot done. So I asked them to do the stent enhancement technique, and you can see that the stent actually is over a calcified plaque and did not fully expand. So the easiest way is to do an expansion of this stent using a bigger balloon. And this is something you should know well, that sometimes the stent design have a different platform between the small and the large one, different in between the brand. And in this case, I use a big balloon 3.5 to post-dilate up to 16 bar, and the balloon fully expand, and then make the balloon easily cross this circumflex the ostium of circumflex. However, because of this stent is a Promus Premier, which will have a 4 link at the two most proximal strut. So I have to use a rotator to do a stent abrasion before make it fully expand, and later use a duct balloon for both parts, for both the band of the LD. And this is another case that the CTO of the ostium LD, and after I opened it and stent with the signature, I did a mistake because I used a 3.5 synergy. stent to send crossover the left main to the LED. What happened? After I use a pot, 5 millimeter balloon pot, you can appreciate in the IVAS that the stent did not fully expanded, not fully position. Why? Because the synergy have the different division of platform. The 3.5 still the workhorse platform, which the most the expansion capacity is only 4.2 millimeter. In this case, you should use the 401. Or in the other brand, the 3.5 may be appropriate. The other point is that the side branch expansion capacity of the stent you should know well, because otherwise, if you put a stent with a small side branch expansion, you cannot make a fully expand of the side branch stent as well. So this is all the case that I gather to in my practice to show how to do with the complex bifurcation. And this means that you should know well about the various technique, various equipment, and also study the angiogram first very well to make a plan to enter to facilitate the success of your procedure without complication. Thank you.
Thank you very much, Dr. Royce. We wish that we had more time to hear from you, but because we have run out of time, so I think we leave the comment and discussion by the end of these sessions.